Thank you very much, Simri. I'm very happy to be here in Thailand another time. I've been here several times just to discuss a point which is very hot nowadays, is the use of second-generation kinase inhibitors in newly diagnosed CML. I'm starting with this slide just to point out that indeed the death related to CML after the introduction of Imatinib in the therapy of CML has greatly changed. As you may see, only 10% in these statistics done at the Hammersmith hospital of patients with CML are still dying because of the disease, very similar to the percentage of the death due to other causes, because most of the patients indeed have achieved at least a complete cytogenetic response. However, another point to be underlined in this slide is that indeed only 50% of the patients after some years from the start of the therapy are still on therapy with Imatinib, and 30% approximately maintain the CCYR status because of other types of treatment. So certainly Imatinib has been a great revolution in the therapy of CML, but we have still room to improve these results. And the major cause of death in CML is certainly related to progression of the disease, to more advanced phases from chronic phase, just as accelerated phase, in particular blast crisis. You know that this is part of the natural history of the disease. Almost 100% of the cases progress. And after progression, the overall survival is still very short. You may see that even in the Imatinib era, and even in patients who progressed after treatment with Imatinib or Dasatinib or Nilotinib in this case, you may see that the overall survival is very, very short. The median overall survival is less than 1 year, and only approximately 15–20% of the patients are long survivors. So why Imatinib is able, or TKI inhibitors are able to inhibit the progression of the disease? Mainly because they are decreasing the number of the target leukemic cells that can progress, and also they are also stabilizing the pH-positive clone, decreasing the propensity to progress of the cells. In this way, they are really decreasing the number of progression. However, we know that this is a slide taken from the famous IRIS study with Imatinib, that indeed there are still some progression, mainly occurring during the first period of the therapy with TKI. And that this progression progressively decreases with time, and I would say become really occasional after a certain number of 2–3 years from the start of the therapy. Now, the problem that we are facing during this period is that if you are using as first-line therapy a more strong TKI inhibitors like Nilotinib and Dasatinib, can we improve the results that we are obtaining with Imatinib? And we will review the data that can be obtained by phase 3 study comparing directly stronger inhibitors like Nilotinib, even specific inhibitors of BCR-ABL with respect to Imatinib, and Imatinib in phase 3 studies I told you. The first study is the ENESTnd study, in which the classical therapy, Imatinib 400 mg once a day, is compared with 2 different dosages of Nilotinib, 300 mg twice a day and 400 mg twice a day. 400 mg twice a day is the dosage that we are using as second-line therapy with Nilotinib after Imatinib failure. In this study, also a lower dose of Nilotinib, 300 mg twice a day, has been tested because it was demonstrated that this dosage was able to give approximately the same concentration or plasma concentration of the drug, and therefore the same inhibition of BCR-ABL together with probably better tolerability. This study is intended for 5 years, and we have now the update of almost 1 year ago, presented at ASH 2011, and we are waiting for ASH 2012 just to have the 4-year update of this study. However, the 3 years update already clearly show that there is a clear superiority of both dosages of nilotinib inducing major molecular response that, as you know, corresponding to 0.1% BCR-ABL represents the safe haven for CML patients, because when patients achieve this rate of molecular remission, really it's very difficult to observe, or they do not have any more risk of progression. As you may see, this difference is maintained with time, and according to the shape of the two curves, that even after 3 years shows a clear gap between the results of nilotinib with respect to those obtained with imatinib, you may see that it's really unlikely that sooner or later imatinib will be able to catch up with the results that have been obtained with nilotinib. Another very important point to stress is indeed that this advantage is mainly observed in patients in the higher risk group. As you may see, there is an advantage statistically significant also for patients in the low so-called risk group, but it is the gap between the two treatments is progressively increasing in favor of nilotinib if we are moving towards the high risk group. And another major point, which is becoming more and more important, is just to observe that the so-called molecular remission 4.5, which is previously defined in some cases like complete molecular response. It means the threshold of BCR-ABL transcript, which is barely visible after a PCR. If we achieve this very low level of residual disease, you may see that there is again a clear superiority of both dosages of nilotinib with respect to imatinib, with almost double the number of patients achieving complete molecular response with nilotinib with respect to what we observe with imatinib. This point is very important because you know that indeed in the complete molecular response is the threshold that we must achieve if we want to try to discontinue the treatment without necessarily observing a relapse of the disease. Probably one of the most important immediate advantage of using second-generation TKI, in this case nilotinib, is just the prevention of the early progressions that are observed with the imatinib therapy. As you may see, for the patients who are remaining on treatment, which are approximately 70–75% of the cases, you may see that there are much less progression if you are using nilotinib with respect to if you are using imatinib, and this difference is statistically significant. Even if we consider as progression simpler appearance of an additional clone with additional cytogenetic abnormalities in addition to the Philadelphia chromosome, you may see that the difference doesn't change. And we can try to have an explanation for this phenomenon just using this cartoon, which underlines an hypothesis that probably, in this case, nilotinib is able to decrease the probability of progression, mainly because it's able to decrease the quantity but also the quality of the residual disease. Indeed, if we are using imatinib, after a while we are remaining of a certain amount of residual disease, which is composed by progenitors, but also by small resistant subclones which are able to resist to imatinib therapy. If we are using nilotinib, we are observing a better, decrease number of residual cells, as well as also the quality of the cells is probably different because there are less imatinib resistant clone. And indeed, this is also underlined by other data that have been obtained in the ENESTnd study. As you may see, most of the progression are occurring within the intermediate and high-risk so-called group. Very few cases are progressing if they, in origin, were low-risk patients. And another point is that if we are observing the number of mutations of clones with mutations which are arising in patients treated with nilotinib or imatinib, you may see that double the number of patients with mutations are observed in the imatinib-treated cohort with respect to what we see in both nilotinib-treated cohort. And even a better, I would say, suggestive information is coming out from the type of the mutations. You may see the 355I mutation, which is totally insensitive to both nilotinib and imatinib, is equally distributed in all the three groups, whereas the mutations which are more sensitive to nilotinib than to imatinib are present only in the imatinib cohort, and this makes the difference. So most of these cases are those who really reduce the number of the mutations. And if we are observing those cases who are progressing, you may see that indeed most of them, 60% of them, have a point mutation. So it means that probably nilotinib, in this case, is able to decrease the propensity of the cells to progress by decreasing the number of cells which can resist the TKI therapy, and which represent really the reservoir of the potentiality of transformation. I already showed to you this slide showing that after progression the survival of the patients is very short, and this is a general observation. Even in patients within the ENESTnd trial, we do not observe any change, absolutely parallel curves, really suggesting that all the progress that we have done so far is mainly in the progression of the, in the prevention of the progression rather than in the treatment of the progression, which is totally incurable, unless that we have the possibility to perform at a certain point a stem cell transplant. We have probably more chances of obtaining a durable remission. Another very important point is that, however, in terms of overall survival, there is only a trend in favor of using nilotinib with respect to imatinib. This is in the general population, but if we concentrate on the death due to CML-related causes, you may see that this difference is statistically superior with respect to imatinib, with respect to nilotinib, with respect to what we see with imatinib. The second generation TKI, dasatinib, is a very, very strong inhibitor, not only of BCR-ABL, but also other kinases like SRC kinases, which are being reported also to be involved in the progression of the disease. And this is the decision study just comparing 100 milligram of dasatinib versus the classical dosage of 400 milligram of imatinib. You may see that after 3 years, the data were presented at THA this year, approximately 70% of the patients are still on treatment in both arms, and these are the statistics in terms of progression, adverse events, and so on. Progression is apparently the same, but definition of progression in this study is different from what it doesn't necessarily mean progression to accelerated phase blast crisis. And you may see that adverse events are a little bit more frequent in dasatinib-treated patients with respect to what we see with imatinib. In terms of measured molecular response, however, you may see that the shape of the curves is very similar to what has been observed with nilotinib, as well as the prevention of progression is again in favor of dasatinib with respect to what we see with imatinib, but both in patients who are on study and patients which are in treatment, as well as patients who are on study but maybe after discontinuation of this specific treatment. And the difference is not statistically significant. This is rather strange, but what is very important is that if we are observing data of second generation TKI like bosutinib, which is not really registered so far, however, it exactly shows the same trend in favor of a great decrease of the transformation to accelerated phase, blastic phase. So it seems that this is a phenomenon which is consolidated. Certainly there is the prevention of some of the progression if we are using a stronger TKI inhibitor with respect to imatinib. Another very important point, and this is the final point, and we will see also today that one of the major advantages that has been observed in the last year has been just an early prediction of those patients who are going to respond well to TKI therapy with respect to those who are not going to respond well. And this is the fact that this early prediction can already be done at 3 months by evaluating the percentage of the BCR-ABL transcript. As you may see in this slide, the first to point out this aspect where the German, with this, in this German 4 study, clearly showing that a threshold of 10% BCR-ABL after 3 months was able to predict event-free survival as well as also progression-free survival as well as also overall survival. And what can be seen clearly is that if we're with dasatinib, you may see that the patients who are not achieving this threshold are much less if we are using dasatinib with respect if we are using imatinib. And the outcome of the patients who are not achieving 10% is exactly the same with both drugs. The same phenomenon is observed also with nilotinib, even more pronounced. You see that those patients who are not achieving the threshold of 10%, only 9% if you are using nilotinib, with respect to 33, 1/3 if you are using imatinib. So altogether, by putting together all this data, we can say that certainly the advantages of using second-generation TKI with respect to imatinib are faster, deeper responses, less progression events, and an early identification of those patients with an inferior outcome, which is becoming, of course, a very important point because we can decide on additional therapies for this group of patients that we know in advance are not going to have a very, very good outcome. So another point that is totally still to be verified, but is very attractive, of course, that we are moving towards a new type of goal in CML therapy, which is not only just to save the life of our patients, but also to have the possibility to really cure them, discontinuing the therapy. And so just really to get rid, at least for a very long time, of the pH-positive clone. So we do not know exactly because there are very few data, but we greatly think that indeed a higher, faster possibility of treatment and discontinuation will be achieved with stronger TKI inhibitors like second-generation TKI. A great problem, however, is now related to which is the first choice as first-line therapy for CML. And these are different possibilities. As you know, we can decide to use independently from the initial risk a more potent TKI inhibitors as first-line therapy. We can just leave or decide to use stronger TKI inhibitors only for a specific subgroup of patients, like patients with a higher risk of transformation. Then another possibility is still to be verified is just to start with imatinib and then to move to second-generation TKIs, only those patients who are not responding very, very well to the therapy. So we are at the moment waiting for the European Leukemia Net new recommendation that will be published in 2013. You may see that in case of non-optimal response to imatinib as first-line therapy, we can probably move to second-generation TKI, but we do not know exactly which will be the clinical benefit. If we are using an optimal response to second-generation TKIs, we are reducing the number of the patients, but really for the moment, we do not know which are the other therapeutic options. We are really excited by the data that have been presented with the third-generation TKIs like ponatinib, recently at ASH. Of course, we have the possibility, and we will discuss this later, to move some patients to allogeneic stem cell transplantation. And we have several attempts just to develop investigational therapies for these patients. Thank you very much for your attention.